Yes, in fact, I agree that aspirin has been there for a very long time. Unfortunately, when things are there for a very long time, they either go into oblivion or people take it for granted for what it's known to do rather than for what it's capable of doing. And I would say that most of the current interest surrounding aspirin is primarily on whether it's of net benefit in people who are otherwise healthy, i.e., whether it gives them a lot of benefit and yet does not give them enough harm. And secondly, a new side to the story of aspirin is whether it's useful for any cancer outcomes. And a lot of research has gone into it in the recent times. So to emphasize at the very outset, this was a meta-analysis of primary prevention trials, which means that the population studied were essentially healthy, except that they were at risk for cardiovascular disease in future. Now there are two sides again to the story. One is we found that there was no net benefit of giving aspirin for the primary prevention of cardiovascular events, and that's because although the benefit of aspirin was with regard to the prevention of non-fatal cardiovascular events, it could not prevent fatal cardiovascular events. As well as that, it was associated with a significant excess harm of bleeding episodes, a lot of them which were major bleeding episodes like the bleeding that you tend to see from the GI tract or fatal bleeding events. And in a sense, the benefit was proportionately offset by the risk of bleeding. And that's something that we have to be wary about when we prescribe aspirin to otherwise healthy people and medicalize them. The second storyline to that is we did not find, unlike previous suggestions, that aspirin does indeed prevent cancer death in people who are otherwise healthy. But having said that, one must acknowledge the fact that these were trials which were not primarily focused at looking cancer outcomes, and therefore a lot more needs to be done to clarify this issue. This was in fact one of the findings of an earlier meta-analysis rather than our own work. In fact, if we have a closer look at the work that we published, what it does suggest is there's hardly any gender difference between men and women as regards the benefits of aspirin on cardiovascular events. And what we believe was the problem with the earlier reports was that it could probably be some kind of a chance phenomenon, which might not be entirely biologically plausible. I would say the jury is still out whether we can declare aspirin as being the wonder drug or not. For example, an important piece of research finding that we observed was in the current era when we have other drugs like statins and other disease modifying agents, it's hard to say that aspirin alone would be effective because generally people who get aspirin are also co-prescribed other molecules, and for that reason the benefits seem to be far less in the modern day treatment of cardiovascular disease and prevention rather than they might have been, say for example, a couple of decades ago. So I would not call it a wonder drug just as yet. Well, it could certainly be included or tested in the polypill strategy for more reasons than one. First of all, although an overall benefit of the polypill strategy has been found in some studies, what needs to be done in future is to identify specific at-risk groups that might most benefit from this approach rather than give polypill to everybody, say for example above a certain age group. And besides, what importantly needs to be established is whether the polypill approach is equally good for preventing cancer outcomes. And therefore, I think a lot of exciting work is to be seen in future studies.